we've come to appreciate that lung cancer is not one disease. These are cancers within the lungs, but lung cancer is really a family of related diseases. And lung cancer, really all cancers, are genetic in origin. When I say genetic, I don't necessarily mean something we inherit from our parents or pass on to our children. Really, it's a change in our genes, a change in the DNA. We call those changes mutations, fusions, rearrangements. The terminology is not so important, but the DNA, which is the code for that cell, when that DNA is changed, it changes the behavior of that cell. So a normal lung cell may be programmed to live a certain amount of time, to stay placed in the lung, and to really grow to a certain size. When we change the DNA, we change the behavior. We allow it to break those rules, and then now this lung cell can grow bigger than it should. It can live longer than it should. It can move to places it's not supposed to. Those changes in behavior are what make that normal cell a cancer cell. Now, in some cases, those mutations are sort of brought about by carcinogens, by different toxins like cigarette smoke, by smoking tobacco. Those will introduce many different mutations, and over time, that combination of mutations will lead to a cancer. But sometimes, for unclear reasons, there's just a single important mutation, important change in the DNA. We call that a driver mutation. There's really only one driver, and that's driving the cancer, that's pushing it forward. So that single change takes the normal cell into a cancer cell. And if there's a single change, there's no guesswork as to what's important. That's the important change. And sometimes if we know enough about it, we can design a drug to really target that change. So if this mutation is like a big switch that's being turned on, we can develop a pill that'll turn that switch off or cut the wires to that switch so that now this cell, which is programmed to go, can't do so. And that's targeted therapy. These are typically oral drugs, though not always, but they're highly selective. They work very well. If given in the right circumstance, they will work for most people. They will work for quite a long time. And because they're targeting this change within the cancer, they'll be a lot more tolerable. They have fewer side effects because they won't have the same effect on our normal cells. And that's sort of the essence of targeted therapy. And it's really important when you're treating lung cancer to know if those mutations are present or absent. If the mutation is present, the drug is likely to work. If the mutation is absent, the drug will not work. But it also influences how well other drugs work. If these mutations are present, immunotherapy might be much less likely to work. So knowledge is really important. We want to know more than just lung cancer or not. We want to know the type of lung cancer. And by type, we really mean the molecular signature, the genotype, the presence or absence of these specific mutations.